the first part of my lecture will be to try to, because you know, we have been talking about pathology these days, quite, I mean, commonly joking about pathologists, and I absolutely agree with that, because pathologists have a very important role, in my opinion. But in most of the cases, or I mean, sometimes they tend to forget that they should be central to the process of precision medicine. So they are basically not, I mean, not willing to be that much involved in this process. And I think that this could affect the general success of the process as a whole. So in my opinion, pathology is a high-tech hub for translational medicine, because there is a very, I mean, simple thing that we have to keep in mind, that in most of the, at least in the Italian hospitals, but I mean, as far as I'm concerned, in Europe and in the US is roughly the same. In the pathology lab, you have a certified lab. So in the pathology departments have labs that can get the diagnostic process. So this is very important, in my opinion, should be exploited also for the process of precision medicine. Because, you know, there is the pathology lab, and we have already established the very, I mean, set procedures concerning the clinical practice, all the regulations, and we are, of course, we are in contact. We are in close contact with the national health system, and we are, I mean, quite, I mean, accustomed to get funding for research and also for the clinical practice. We are following guidelines, and we are in close contact with preclinical labs. This is a quite, I mean, fortunate situation, in my opinion. And first of all, we have a very important task in exploiting our biobanking. Usually, the biobank, the chance in the past to run a biobank, unfortunately, it was a biobank and not a bank. But you never know in the future. You never know. I mean, what was very fun, in my opinion, that in most of my colleagues, especially the clinicians, but also the pathologists, thought that biobanking is the activity of frozen tissue. The frozen tissue is the biobank, and the formalin fixed paraffin embedded is another story. This is untrue, absolutely. The biobank is all the tissue that is stored in a hospital. So there is the formalin fixed paraffin embedded tissue and the frozen tissue. And this is the same, because we know now that by using the new technologies, we can exploit tissue, even if it is frozen or formalin fixed and paraffin embedded. I mean, more than that, I think that now a biobank should be more devoted to collect fresh tissue and develop within, I mean, along with the scientist, I mean, the chance to develop cell lines, organoids, so working on fresh tissue on specific projects that can be run along with the internal scientists, but also for the rest of the world. And they can be done quite easily. So we can apply the rules of the biobank to formalin fixed and paraffin embedded tissue. So, for example, in the hospital where I'm working now, we have tissue. I mean, we have been collecting tissue from the first years of the past century. So we are plenty of very well characterized samples that can be very useful in order to achieve level of evidence for example, in retrospective series when we are dealing with a biomarker, for example. So please use the biobanking as, I mean, a concept, a unifying concept. Formalin fixed and paraffin and fresh and frozen tissue is the same. Then this is what we can do, but this is not, I mean, is not advertising. This is what can be done in most of the pathology labs around the world. So we do a lot of work for our patients, and I think that we can exploit all this job for research as well, and for precision medicine especially. I mean, the tricky thing here is trying to be involved in the process. But as far as you are involved in a process of collecting data and being I mean, I would say in the center, but you can be also at the edge of the process, but involved in the process of precision medicine. We can get a lot of data for treating patients and also, of course, for clinical research. So basically, we have a very skilled personnel because, you know, the technology we use for diagnosis and achieving the predictive and prognostic factors for our patients are the same that can be used for biomarker validation, for example. So we have a very skilled personnel to do both things. We have a training approach, we have technology to do that, and we applied quite well-certified procedures. And so we can get to the research or to other colleagues or the consortia. We can get the template. For example, we can get RNA, DNA, or protein in order to get research, but also data. And maybe in most of the cases we can get template and data together: clinical data, pathological data, expression data, and so on. So our job has changed. This is, I mean, the times they are changing. I think that the times have already changed. And in the past, you know, we were accustomed to get surgery, then diagnosis and treatment, and that was all our job. So the diagnosis and the treatment of the patients were closely related, were basically the same. All the treatments were conceived according to the diagnosis. So you had probably in mind a pathologist that were working on the microscope 2-3 hours, just watching scanning slides and trying to get the right diagnosis just in order to have the best treatment. Now, you know, diagnosis is still important. I mean, at least if you want to avoid to get in jail. But that is quite important, you know, because you can. It is better to be free. But most of the work we do now is to collect predictive and prognostic factor, and we are we are dealing not only with surgery, with surgical samples, but more and more with biopsy and also with plasma, saliva, and urine, just in order to detect the template which are useful for treating patients. This is just, I mean, clinical. Our clinical involvement that, as I told you, can be exploited for research as well. I mean, in my opinion, now we have to decide, because we have to apply. We are going to apply very complex technologies, including Nextgen. But this is just one of the choices we have to do. Together with our clinicians and also with the administrative of the hospital. I'm working in a cancer center, so we are using to get next generation sequencing analysis in my institute. But I think that if we keep all the procedures we have been already talk about in the previous slides, we can generate a template that can be very fairly and precisely used for further characterization. And the further characterization may be done centrally in your hospital if this is economically sustainable, if you are skilled personnel, money, technology, continuous training, and so on. But you can also decide to externalize some or all or a part of your analysis. Of course, I mean, I'm involved in the university. I'm serving the University of Milan as well. So the educational issue is very important. This is what the pathologists are doing in their 5 years, 5 or 4 now, I think, 4 years, course, postgraduate course of pathologists. They are doing autopsy, surgical pathology, cytology, a bit immunohistochemistry, interpretation, just interpretation, not lab work, but just the interpretation of immunohistochemistry, the grading, staging, intraoperative exam, and that's it. So it's not enough. I mean, I think that maybe someday I will be able to get in touch with the postgraduate school of Milan. And in my opinion, I think that we have to radically change the education of pathologists. So the pathologists should be involved in the molecular labs from the very beginning. Maybe the first 2 years, or maybe 1 year, or maybe 2 months, I don't know. They may be taught that of all these things, but then they have to be devoted of the other tasks. So they should be involved in molecular labs. They should be involved in molecular tumor board, because we should be involved in multidisciplinary teams where we should not just confirm that the tumor is ductal carcinoma 2 centimeters and that's it. We should maybe comment and discuss the specific type of mutations that specific tumor has, and again, this mutation may be generated in your own hospital or by an externalization process. That's absolutely not important at the moment. And then, of course, we should, pathology should be also involved in bioinformatics, oncology, pharmacology. They should have stages abroad, of course, and also some ethics and psychology, especially, this is psychology is especially for the pathologists themselves, you know, not for talking with the patient. No, now I'm joking, but we have, we are more and more involved in a relationship with our patients. So we should have some people that could teach us as to have this kind of relationship that is very, very, very difficult. So the second part of my presentation will be I will be trying to describe how we can be useful as a pathologist, but as an oncologist, in applying the technology. Because we have been talk about the fact that technology is costly, is expensive, so we should try to to focus the use of technology to that specific settings for which technology is particularly useful. Try to save money and to be more effective. So this is the currently accepted prognostic predictive parameters for breast cancer, as discussed in St. Gallen. And you see that most of them are, very traditional. You see the tumor grade, tumor stage, the perivascular tumor, peritumoral vascular invasion, receptor status. There are some biomarkers, HER2. We will be discussing about Ki-67 just in a minute. So there are nothing new, There is, some very traditional data here. But we know that this is not enough, so we need, the oncologist, our patient needs something new, and we have to try to develop these new parameters together in order to get more insight into the biology of the tumor, in order to establish especially the chemotherapy, endocrine therapy sensitivity, and also prognosis, but especially the biology and the predictive markers. We can use a very, this is very, you see, old slide, so this is an old study. The slide is new, but where I outlined the very important, the watershed paper by the group of Chuck Peru. This was in DNA microarray, and they were able to establish that different molecular subtypes of breast cancer. But this is not very important. It's just to get an example. And this is, I would like to comment these two slides, because you see, if you are using a very costly, a very expensive test, of course, the cost is an issue. And so you can check the validity, the clinical validity of the test in a very small population of patients. In this paper, there were just, 48 or 50 patients. So we start as a pathologist to do our dirty job, trying to find a surrogate that could be useful just in order to distribute the test and to check whether the test had clinical validity in the breast cancer population. And so we did that by immunohistochemistry, useful. And so if you use a cheaper method, a most cheaper method in the very same specimen, you see that you can have a more meaningful clinical validation of your biomarkers. Of course, you are losing precision, but at least you are getting a validated result. And in fact, you know that in breast cancer, we are using immunohistochemistry in order to differentiate between molecular intrinsic subtypes. We are using to talk about luminal A, luminal B, HER2 enriched in breast cancer, but we know that we are not, strictly adhering to the definition of these different intrinsic subtypes, because we are using immunohistochemistry and not molecular methods. We can treat, our oncologists can treat patients according to this method, but there is a gray zone where there is some uncertainties to get or not, to get chemotherapy or just treating the patients according to endocrine therapy. So the model is that I'm talking with the not breast maniacs now. If you have just a luminal A, so a tumor that is not that proliferating, you can just treat the patient with endocrine therapy. If the tumor is more proliferating, ER positive and more proliferating, it is better to add chemotherapies to endocrine therapy. But you can very well separate two populations, a population that should be treated by chemotherapy, by traditional clinical pathological parameters, and another population that should not receive chemotherapy. But then there are quite 30% of patients in the middle, and we don't know how to treat them. We try to do our best by immunohistochemistry. Okay, I think that Ki67 is for example, is a quite fine, a decent companion in our daily job. So this is an example. You see, this is a lymph node. This is a germinal center, and you see the brown is Ki67. You see, this germinal center is highly proliferating. But then you can see that there are a breast cancer metastasis here. So by this method, you can, very nicely dissecting the normal tissue, highly proliferating, from the neoplastic tissue that is quite slowly proliferating. So it's fine. You can use Ki67. The problem is that we don't know how to count it. In my own lab, I can get you the best Ki67 results. The problem is that in another lab, probably if I assess a tumor as 25% in the lab at the Istituto Nazionale Tumori, at the Yale, the same slide would be scored as mine was 25, in Yale would be 22, 15, 28. So it is not a reproducible method. So, and then there are some problems with ER and PGR, but let's focus on Ki67. I have been involved in this, so I'm not, cheating them, okay? Because I was part of this meeting. But let's see how was difficult to try to get, a procedure, a reproducible procedure. This is, in my opinion, is very funny. The threshold of Brown considered positive. So we have been discussed of the significance of Brown. What is Brown? You know. And for the people that is fond of philosophy, probably you are thinking about Kant. You know Immanuel Kant, that you have the concept of Brown inside you. But my concept of Brown can be different from your concept of Brown. So, it's a nightmare. We tried to do that. We had some results, but at the end of the day, we were not able to be reproducible. And that has been, definitely stated, very clearly stated in the MINDA trial. The MINDA trial was a trial, a prospective trial assessing the 70 genes panel developed by the Dutch people in breast cancer. And they were, it was a quite complex trial. We have not time to discuss it. But the funny thing was that they, basically compare the molecular data with the traditional clinical pathological data. And in the traditional clinical pathological data, there were ER, PGR, the lymph node status, the grade, but there was no Ki-67. So I think that we should be sincere enough to admit that we are not able to score Ki-67. So since proliferation is so important to decide whether or not to get chemotherapy to our patients, we should adopt some of these prognosticators that you know very well. They are different. They are different. They are coming from the market. So one of the problems is to decide which of them you should be using. And so this is, I mean, this is a problem in the daily practice. And this problem in the daily practice, this is just an example. You can apply this example to all the technologies you had to get in your lab, a software, a new technology for NGS, a new panel, and so on. So you have to decide. These are the panels. So I'm still playing as I was a scientist, so I prefer this one. But this is just my preference because there are a lot of genes inside, you see. There is a lot of biology. This is the prosigna, but then there are the others. And all these have been proved to outperform the traditional clinical pathological analysis. So they are better than what we did in the past. This is one of the most used prognosticators in breast cancer. It's oncotype, so please be skeptical. Try to analyze what the test is giving to you. So this is a test with 21 genes. Most of them are related to ER, PGR, HER2, and there are a set of gene of proliferation. And you see that the proliferation is weighting a lot in assessing the risk score to the breast cancer patients. So the low-risk patients, at the end of the day, should be treated by endocrine therapy only, and the high risk by endocrine therapy plus chemotherapy. This is very important in my opinion. This Jack Cusick did very interesting exercise. He evaluated immunohistochemistry and the new data in the very same specimens. And at least in his own lab, he was able to assess that there was no that difference between the prognosticators and the immunohistochemistry. So immunohistochemistry is quite good in assessing the risk of the patient, but we know that. The problem is the reproducibility again. This is one of the most critical issues in detecting predictive factors in breast cancer. So, and in fact, they conclude that if you have the best quality in the world, you can use immunohistochemistry. But most of the other labs are not the best in the world. So they are second position, third position, and so on. So again, using an objective, reproducible, and I would say sophisticated and validated method, it is better than use just immunohistochemistry. So the question is, so should we use a prognosticator from the market for all the patients with ER positive breast cancer and HER2 positive breast cancer? This population is roughly 75% of all the breast cancer patients. In Italy, we have 40,000 new cases of breast cancer patients per year. And if you are, and for example, Oncotype is costing 3,000 euros per test. So I think that we should try to get, a meaningful way, just in order to select, to fine-tune the population that should be evaluated by this test. And again, this is just a model, because if you have not an NGS lab in your hospital, and you have to externalize the analysis of Nextgen, you should ask, should I just run Nextgen in all the patients, of the cancer patient in my hospital, or should I try to talk with the oncologist and try to find out the setting that should be evaluated by NGS? So we did this exercise. This is just immunohistochemistry. You see that by using immunohistochemistry, at least in our own lab, you know, this is a single institution experience. We were able to dissect two populations according to the proliferation, evaluated by Ki-67 again. And the luminal A behaved quite well, 95% of survival at 10 years. So I would not evaluate by oncotype this population. I would for sure evaluate by oncotype this population, because in this population probably there are patients that should have been treated by chemotherapy or patients treated by endocrine treatment only. I mean, so this is my conclusion here, that probably we should try to have the best solution for us and for our patient in our specific setting. So in my specific setting, I think that I would get Ki-67 because I'm quite fine with Ki-67. I have a very, I mean, important master of the Ki-67, encountered the master of Ki-67 in my life, that is Professor Viale, so I'm fine with Ki-67. I'm quite confident with that. I can use Ki-67 in order to define a population of tumor that is proliferating, you know, 15%, 20%, 25%, and according to the other clinical pathological characteristics, within a multidisciplinary team, we can discuss and decide which kind of tumor should be evaluated by the most sophisticated techniques. Then I would like to have at least two risk categories, because there is a psychological problem when you have a patient that is paying for the test, because these tests are not yet reimbursed in Italy. If you have a patient and you have, I mean, and you run the oncotype, you got three categories, and of course the patient want to have, I mean, very straightforward information. But in most of the equivocal cases by the immunohistochemistry, you get, I mean, again, an intermediate risk category. So you have to start discussing again with the patient. They should be distributed because, in my opinion, in this case, I think, at least in my experience, they should be distributed. But it would be, I mean, a system like that for characterizing central nervous system tumors. I think that the last time I saw a central nervous system tumor, it was 21, 22. So I think that I would use that, I would prefer to externalize the analysis. And then, of course, the reimbursement by health system is very important. Okay, so I think that this last slide is just to remind us that we have always to select our patient. There is no, I mean, a special technology that is able to give you all the answer to all the problem of your patients in all the situation, in all the setting for every patient. Also taking into account, I mean, the specificity of each specific patient. Okay, thank you very much.